I'd like to know the panel's input on how you or your assistant approaches prepping a patient prior to doing any of these procedures.
If you look at the Lyme sepsis literature in hospitals, they've sort of studied what you can clean the face with to really reduce the incidence of infections. And it's 2% chlorhexidine and 70% alcohol. And we use sterile water, we just pour it in a cup to clean faces because there are biofilms of mycobacterium in tap water. And if you're doing a ton of injections, I mean, the odds are that something's not going to happen to you. It's not very common, but you can reduce that even further by using sterile water.
Very good question. In my office, I analyze the patient first and use a white waxy marker. The patient has a mirror. We're marking out the areas where we agree that product is needed. And then we have the patient wash with chlorhexidine. There is some debate as to whether or not chlorhexidine could be damaging if you get it in the eye. I tell patients to be quite careful not to get it in their eye when they're doing their facial wash with it. And then I come back around with an alcohol swab. Alcohol remains a really excellent antimicrobial. I wipe the area, dries very quickly, and then I replace my markings and start injecting.
I think the most important thing is simple face washing. Just like cutting down nosocomial infections, it's simple hand washing in a hospital. For me, the choice of which agent is much less important as mechanically cleaning that skin. Almost no one comes in with clean skin. They've got some sort of moisturizer or makeup on, filled with bacteria, crammed into their pores, and it doesn't really matter unless you mechanically cleanse their skin and get all that junk out of there. And so we have them scrub with a facial scrub. Patients rarely wash their face very well, and then I will sit there with an old-fashioned gauze and alcohol and keep rubbing until that gauze is completely white. And it takes a long time, and they don't like it. But I think it's by far the most important thing, rather than choice of agent.
I have my assistant go in and prep the skin with Hibiclens. Then she applies the topical anesthetic. I don't like to cause pain. I like to try to make things gentle. So she applies the topical anesthetic. I'm always running behind, so that gets to sit for a while. And then I go in, and with my assistant, we take the gauze and alcohol, which I think not only helps in terms of removing bacteria and is bacteriostatic, but I think that it degreases the skin. And so I really like using the alcohol after the Hibiclens, and that degreases the skin. Then I use my marking pen. I try diligently not to put, because I don't inject with a sterile glove, I inject with a clean glove. And I try not to put my hand on the needle or the cannula. And I think that's been one potential concern with using the long cannulas, is sometimes with the difficulty getting them in the skin, we're putting that non-sterile gloved hand down on the shaft of that cannula, trying to work it into the skin and manipulate it. So I think that we really have to look at good, clean technique, especially going forward as we have longer lasting type of implants that we're going to be putting in faces. That it's sort of like if you develop good technique for what we have now, hopefully then that will relate to less problems going forward.
How many people on this panel have actually gotten an infection from a filler or Botox injection? Because I've never had one, and I wonder what the reason for that is.
I haven't. I think the vascularity of the face is so great that, and we have, is probably the reason why, because we're certainly putting bacteria into the face with injections. The only time I've had an infection, and this is a pearl, was a woman I was injecting with Sculptra, and it wasn't the Sculptra. It was a patient who failed in her history to tell me that, though we ask everybody whether they have any implants, and I got down to the chin and I hit something that felt unlike bone. With the 25 gauge needle, I had violated the capsule of the chin implant, and I didn't even inject. I said, "Do you have a chin implant?" She said, "Yeah." She had about 2 weeks of IV antibiotics, and I finally convinced her to take the implant out. So the pearl here is, I would warn everybody not to violate the capsule of implants because it's an avascular space, and whatever little one bacteria cell can sometimes cause a huge problem there.